Hi, everyone. Good morning. Today, we're joined by Dr. Brandon Webb, an infectious disease physician here at Intermountain Healthcare, to give our weekly COVID-19 update. Dr. Webb, thanks so much for joining us.
Thank you.
I'm going to read off yesterday's case count numbers just so everyone is aware. These numbers are from the holiday weekend, but just so everyone has those, I'll do those first. The case counts were reported at 4,657, which was up 165 from the previous weekend. We had 1,151 school-aged cases and 27 deaths reported. Our hospitalizations yesterday stood at 482, and our 7-day percent positive rate was at 12.6%. For our vaccination percentage, we're at 48.9% fully vaccinated across the entire population and 61.5% vaccinated for those who are eligible, which is the 12 and older. Dr. Webb, let's start talking a little bit about capacity. How are our hospitals doing? What is the atmosphere like right now?
We're at capacity or above capacity at all of the major COVID hubs across the Intermountain system. Some of our major COVID hospitals are actually well above capacity and are having to use creative means of maintaining access for patients in the ICU. Like we've talked about on previous Facebook Lives, I think morale is an issue. Staffing remains an issue. We're continuing to load level and to use creative means of identifying ways of continuing to provide care for patients, whether they have COVID or non-COVID disease.
I want to run a scenario past you really quickly. We got this question sent to us. There is a grandmother who has a grandson who currently lives with her as well as the mom. And the grandson got vaccinated, his first dose last week, and she was curious around if it's possible to spread COVID before someone actually becomes symptomatic and kind of what precautions she should take as someone who's older and immunocompromised, living with someone who's younger and just got their first dose.
Yeah, so I think there's a couple of things around that scenario that we could talk about. First of all, kudos to grandson for getting the vaccine. I think it's important to recognize that the vaccine takes time to build up immunity. And so until that individual who's vaccinated is fully vaccinated, it's still possible to be exposed to COVID and to get the virus and to transmit it. And so I think that there are some things that those in the community, like the grandmother in this vignette, who are at higher risk, need to be aware of. First is to understand their individual risk and to change their behavior in a way that decreases that risk. So I think that we have multi-generational families. We have large families in Utah, and it's important to recognize that a lot of our transmission comes from those gatherings with people that we're closest with. So I think in this vignette, we would advise that those individuals who share a household and have very different risk levels need to recognize that individuals like the grandmother who are at higher risk need to take additional precautions that will enhance the benefits of vaccination, especially until that vaccinated individual is fully vaccinated.
And the part about symptomatic versus not symptomatic too, is there like a time period typically if someone does have COVID? Is it day 3 that you're most contagious? Do we know anything about that specifically?
Yeah, and that's one of the challenges with COVID. Like other viral infections, the contagious period starts several days before symptoms start and actually peaks right around the time that symptoms begin and for the first couple of days after the onset of symptoms. So people with COVID are actually contagious for several days before they even realize that they have the infection, and especially for several days after the symptoms start. And that's especially tricky because a lot of times symptoms start with a runny nose or a sore throat or headache or fatigue, mild symptoms that then increase over time. And I think it's really important for the public to be aware that recognizing that even those mild symptoms can be a signal that you have COVID. And we want people to get tested early in their symptom course, not only so that they can take the appropriate precautions and isolate, but also it opens doors for treatment options as well.
A question for you around those like starting symptoms. The air quality has been pretty terrible for the last few days in Utah. Can smoke and bad air quality cause like the same symptoms that COVID could potentially cause? And if that's the case, regardless, should you still go get tested?
Yeah, we're in a tricky spot because the pollen counts are up, fall allergies are up. The air quality for many people does create respiratory symptoms that do overlap with the symptoms of COVID. And I think the takeaway is that although they can overlap, if you develop respiratory symptoms that are new, you really should get tested. It's important to know whether or not you have COVID-19. And we hope that a lot of folks with respiratory symptoms have seasonal allergies or are suffering from poor air quality. But with the high case transmission in the community right now, it's very important to get tested, even with mild respiratory symptoms.
I want to go back a little bit to staffing. Can you talk to us a little bit more about the morale that you're seeing in your hospitals, as well as if any staffing issues are impacting care, if we're having to change anything around how and what happens in a hospital when someone comes in?
Yes, staffing is critical right now. It is the rate limiting step for continuing to provide top quality care. And we're seeing fatigue, especially on the faces of nursing and other healthcare providers that are on the front lines. We're also seeing an increasing number of individuals who are having to take time off of work because they're caregivers at home and their children or other dependents are getting sick and needing to be tested and go to the doctor themselves. And that's taking away from our workforce. And we expect, unfortunately, that type of thing, those household exposures will continue to impact our workforce as well. So, just to take a big step back, I think morale suffers when we don't have enough staff, and that's certainly the case right now. We're having to, like I said before, be creative with our staffing models so that we're able to accommodate and continue to provide good care for patients with COVID and for those without COVID.
This past weekend was Labor Day as well. Do you think that there is going to be a surge in cases, which will then lead to maybe hospitalizations and deaths from this weekend?
I think it's likely. I think that historically, anytime we've had holidays and gatherings, we have an increase in case counts in the community, and we're bracing for that. I think we expect that over the next couple of weeks, we likely will see increased numbers of new cases, and new cases then lead to new hospitalizations.
Another question around that too, is it possible to tell a difference between a Labor Day surge and maybe something like a start to school surge or any other events that maybe happened this past week? And if that's the case, we were contact tracing very heavily last year. Is that still happening right now too?
It's going to be difficult when multiple events are all occurring simultaneously in the community. We're able to watch epidemiological trends, for example, case counts in the school age population. We're also able to look at the timing of increases in cases and increases in test seeking, but it will be difficult to tease out as we go into the next few weeks what is attributable to Labor Day gatherings and what is attributable, for example, to back to school. I know that the Department of Health and the county health departments are also limited by staffing and are doing their best with contact tracing. That's especially important as they interact and assist with the school districts. And a lot of the county health contact tracing is focused on supporting those school districts with accurate case counts and transmission numbers.
You mentioned this a second ago as well, that you should be getting tested early. And last week, it seemed like a lot more people needed to get tested, whether they were exposed or they had symptoms themselves. Do you feel like a lot of these results that could potentially come in are delayed positive tests where people had to wait to get tested, or does that even really matter in the scheme of things?
I think our availability of testing right now leaves something to be desired. We really do need to ramp up the availability of testing and the turnaround times. I think we're all hearing about patients who are going in for testing and not getting their test results back for 2 or 3 days. And let me just talk big picture for a minute. All of those preventive measures that we're talking about right now, the availability of testing, contact tracing, testing early and isolating, quarantining after exposure, wearing masks in indoor settings, limiting gatherings. All of those are very effective means for rapidly decreasing transmission in our community. And that really needs to be a focus, because in order to prevent the continued emergence of new variants, we have to do 2 things simultaneously. We need to rapidly decrease the number of infected individuals who play host to these mutating viruses. And we also, at the same time, need to increase the number of immune individuals in our community. And both of those are interdependent, both are absolutely essential. This has never been masks versus vaccines. In reality, we need to use all of the tools that are at our disposal to rapidly decrease the number of transmission events and to rapidly increase the number of immune individuals in the pool, so that this vicious cycle of new mutated variants stops. That's our goal. That's the big picture. And like I said, both increasing the immune buffer in our community and decreasing transmission are equally important.
A question around that too with variants, we keep getting asked this probably every week or almost every day. Is there a way to test for the specific variants? If someone comes in to get tested, do we tell them what variant they specifically have?
So testing for variants requires genetic sequencing, and it's not something that can be done on a point of care or rapid basis. So those assessments, the genetic testing has to be done after the fact using specialized laboratory equipment. So for that reason, we are unable to rapidly identify mutants or variant strains, and we're not able to communicate that to individuals as they test positive. But on the back end, the Utah Public Health Laboratory is working hard to increase their sequencing throughput so that we do and are able to identify the percentage of new cases that are due to each evolving mutant or variant strain.
And will you just talk about too really quick that around treatment for the different variants, and if that differs at all, like to the common consumer, should it matter what variant of of COVID that I have?
It really doesn't matter from a clinical standpoint. All of the variants right now have very similar profiles in terms of the mutations. We're tracking those variant strains that do have mutations that would require different treatments as far as monoclonal antibodies go. And we and the Department of Health and Human Services and the Utah Department of Health are using that data to track that very carefully so that we are using the right treatment for the variants that are dominant right now. But overall and in general, the treatment and the treatment options that are currently available don't change. They're equally effective right now from variant strain to variant strain.
While we're on the topic of variants, can we talk a little bit more about the different variants that we're hearing about? We started hearing about Mu very recently, and the Lambda variant has been around for a little bit. Do we know anything about these variants and what the severity of the illness is for those specifically?
We're just getting more information about Mu. We know that it's prevalent in a number of countries. We know that it originated likely in South America, but it's been found in more than 40 countries now. It has similar mutations to some of the other variants that are currently circulating. We don't have full understanding yet of how well protective the vaccines will be against mu. We expect that they will have adequate protection based on the mutations that we know that mu carries. And right now, it's very important for us to observe whether mu and lambda are more transmissible, whether they're able to outcompete delta. Because one thing that we do know is that delta is prolific. It's extremely transmissible, 2 to 3 times more transmissible than alpha and some of the previous variants. And it generates significantly higher numbers of viral particles. And that's important because that actually, it leads to increased transmission and is one of the reasons why we're seeing, it's actually one of the reasons why it's important to continue to emphasize these preventive measures as well.
Let's talk about the vaccine. We have a lot of questions. We've gotten so many questions today too, so I don't know if I'll be able to get to all of them. But let's start with natural immunity versus vaccine immunity. There has been lots of conversations around this. Can you talk to us about the recent reports that were released?
Yeah, let's just address that head on. I think it's really important to understand what we know and the implications of what we've learned just in the last couple of weeks. Since the last time I did Facebook Live, there was a new study from Israel. There was a study that had previously been published from Ohio. And we now have some data from the CDC as well that helps us to have a better understanding of natural immunity and vaccine immunity. So let's tackle both of those. First of all, what we're learning is good news. And what we're learning is that the immunity that is generated for many people after recovering from COVID-19 is stronger than we thought. And that's great news because remember, taking a big step back, one of the keys to success at preventing this vicious cycle of variant emergence is increasing the number of immune individuals in our community. So those who are fortunate to have recovered from COVID-19 and have natural immunity, that's a good thing. Now, that study, the Israeli study, should be looked at as comparing two very good things, comparing natural immunity, which is great, and vaccine-induced immunity. And what they found was that the natural immunity, just like vaccine immunity, varies from person to person, and it also wanes over time. What they also found was that the human immune system is terrific, and that natural immunity, it does appear to be stronger than the immunity that the vaccines are able to elicit in patients who have never had COVID. But the takeaway from that article was not, and I want to be clear on this, that the implications of that observation was not that we should just stop doing vaccinations and allow the virus to spread and generate natural immunity that way. That's a non-viable strategy. It would be catastrophic in terms of lives lost, in terms of overwhelming healthcare systems, in terms of economic impact. There's no question that just pulling off the brakes and allowing the virus to run its course through a community to generate natural immunity would be devastating. So that is not the point of that article. The point of that article is to point out that natural immunity is perhaps stronger than we expected, and that patients who have natural immunity and are then vaccinated are in the best possible situation. And why does that matter? Well, we now understand that even though natural immunity is excellent and may be stronger than vaccine-induced immunity, because they both wane over time, we need to do things that increase the breadth of immunity against new emerging variants. And we also need to do things that increases the length of immunity. And we know that vaccination does both of those, even if you've had COVID. So the messaging, the big picture takeaway here is that I think we do need to reevaluate and get better at assessing the true level of immunity in our community, taking into account natural immunity and vaccination. But vaccination still remains the most effective and widely available and rapidly deployable means of achieving immunity at scale in our community.
I want to ask you a question around this because I know that people are going to hear this and automatically think, I don't have to get the vaccine. Can you talk to us about the risks of getting COVID? Just back to the basics of this gamble of you don't know how your immune system and body is going to react. So what's the benefit, I guess, of getting the vaccine versus what you just said, that this natural immunity could be great, but you don't know what's going to happen to you, if that makes sense?
Absolutely. Let's talk just candidly about should I get the vaccine or not? And I want to just talk directly to people in the community who are still making that decision and recognize that it is a very personal decision. And we understand that although I truly believe, having reviewed literally every scrap of safety data on these vaccines, that at the population level, they are truly safe and effective. At the individual level, for you out there who are making that personal decision, it's actually a personal risk versus personal benefit question. And I, as a physician, every medication that I prescribe has some risk and some benefit, and the vaccines are no different. I think it's really important for those of you who are making those decisions to understand accurately what the risks are and to understand what the benefits are, both to you and to the community. And I'll talk about that for just a minute. We humans, and in our psychology, we're prone to not being objective at evaluating risk. It's just hard for us. You know, we all drive every day, and we don't think about the fact that hopping in the car has a 1 in 8,000 chance of getting in a fatal car accident. You know, we just don't take that into account. So it's hard. It's hard to take risk into account. But I look at these vaccines as tools. They're very important tools for accomplishing the goal of building immunity in our population effectively, rapidly, and safely. And like any other medication that I prescribe, there are some risks. For example, if you've had a Z-Pack, you may not know that the risk of having a fatal cardiac arrhythmia with a Z-Pack is very rare, but it's 2 times higher than having temporary inflammation of the heart after having one of the mRNA vaccines. And we don't think about that. We take Z-Packs all the time. The risks of the vaccines are very real. We have excellent data from Israel and from the vaccine safety data that the CDC is collecting. And I can say right now that after millions of doses administered, we have a good sense of what the adverse event rates are, and they're very, very low. Now, benefits. For those of you who are 30, 40 years old or older and have any chronic medical conditions, including obesity, it's important that you be vaccinated for your own protection. Delta is different in the way that it affects people who previously we didn't consider to be as high of risk. We're seeing more and more, especially men, I'm talking to you guys, men in their late 30s, 40s who are overweight or have other medical conditions that maybe we didn't think about as severe before, who are getting very severe disease with COVID-19. Many are winding up in the hospital. And the vaccine is life-saving for those of you who have those risk factors. And I want to re-emphasize that. For those of you who are fortunate and are not in that position, maybe you're younger, you don't have any chronic medical conditions, you may be wondering, what's the benefit to me? Well, let me go back to the battle that we're facing between the variants and this vicious cycle. We are running out of patients. We all know that. We're running out of ICU beds, but we're also running out of Greek letters. And this vicious cycle of new variants emerging is going to continue. Evolutionary virologists are estimating that this could keep going for 2 to 5 years unless we interrupt the cycle. And the benefit to you is that we need to rapidly increase the immune buffer in our population. We need to work together to engage to get as many immune individuals as we possibly can in a short amount of time, while at the same time decreasing transmission, so that that pool where those variants are able to play host and mutate shrinks rapidly. So that's our plea. I think let's just call it at face value. We recognize that some individuals should be vaccinated because it will protect you from severe disease, and many other individuals we request to be vaccinated because it will help us build up that immune buffer and successfully stop this vicious cycle.
The perspective of 2 to 5 years is very eye-opening, and I appreciate you for saying that. And I think hopefully that point got across to people who are watching. I want to talk about breakthrough cases now too, because a lot of people have questions around that. First question for you, why are breakthrough infections even happening?
Yeah, it's a great question. I think that a lot of us are watching the news and seeing data on breakthrough infections and wondering, if these vaccines are so good, why are we seeing so many breakthrough infections? So let's talk about why those are occurring. I mentioned that Delta is different than other variants. It creates many times more viral particles. So remember that the vaccines create a second line of defense. The first line of defense are the things that we do to prevent exposure. And again, going back to those preventive measures that I talked about, physical distancing, wearing masks indoors, limiting gatherings, all of those prevent exposure by limiting the number of viral particles that you're exposed to. That's critical because, again, if you think about an army attacking a castle wall, the more viral particles attack the first lines of defense, the more likely it is that some will get through. And we're counting on the vaccine to be a second line of defense to then pick up there. But the vaccine can also be overwhelmed if we're just simply exposed to too many overwhelming numbers of viral particles. So that's one of the reasons we are seeing breakthrough infections, is because, frankly, we're not doing as much to prevent the first exposure. And we can decrease breakthrough by being more careful about preventing those first exposures. The second reason we're seeing breakthrough infection is that the vaccine, while excellent, is not perfect. And the individuals who have stronger responses to the vaccine are also individuals who have healthier immune systems. You might be surprised to know, though, that although the risk of having a breakthrough infection is greater with Delta, the vaccines are still markedly effective, even if you have a breakthrough infection. The symptoms are more mild. They last for fewer days. You recover more quickly. There's data that suggests that long COVID symptoms are less after vaccination. And most importantly, even if you have a breakthrough infection, the vaccine, frankly, can be life-saving. It's dramatically effective at preventing hospitalization, ventilation, and death.
I want to expand on the point you talked about with the people that are getting COVID. There's questions around what these people are like, how many comorbidities they have, what are their average age, are they different than the people that are unvaccinated in our hospitals? Can you and Eddie mentioned this a little bit last week, but will you just reiterate what is the main difference is between the two groups of people we're seeing in the hospitals right now?
Yeah, we're seeing two very different groups. Among those who test positive, the average age of those who are unvaccinated is in the 30s, average age. And that spans well below that. The average age of those who have a vaccine breakthrough is in the upper 50s. Right now, roughly 80% of all positive tests are in unvaccinated individuals. And of those 20% that are breakthrough infections, very few of those are requiring hospitalization. So right now, when we look at our hospital census, we have roughly 87% of patients who are in the lower acuity hospital beds are unvaccinated. And more than 90% of those who are in the ICU and more than 93% who are on ventilators are unvaccinated. And really, we don't share those numbers to vaccine shame in any way. We're just sharing those numbers because it's really important to understand that even though breakthroughs do happen, the vaccine is still critically protective against severe disease. And like I said, I'm going to just reemphasize that this has never been about vaccines versus masks. This is about using the full suite of tools that we have available to increase our immune buffer in our community and to decrease the transmission. And if we can do both of those effectively, we can break the cycle.
Another common question we keep getting is, are people that are in the hospital who are unvaccinated, are they reinfections? Meaning, have they had COVID in the past and this is maybe their second bout? Do we know anything about that?
Those are hard numbers because we have data on those who've been tested in the past. And our numbers are similar to some of those studies that have recently come out that suggest that having had COVID, especially in the last 6 months, does generate natural immunity that protects against reinfection. So it's likely that the majority of the new cases in unvaccinated individuals are occurring in COVID naive individuals. But we have to acknowledge that we don't have full visibility on that because we're not doing surveys, not checking for antibody levels and doing asymptomatic screening. So it's likely that the reinfection rate is higher than we estimate, and we simply don't have full visibility on it.
That's good to know. A couple more questions for you. So there is a very large football game happening this weekend with an estimated 63,000 people going to be in a stadium, plus people watching the game in private homes or other areas. Are you anticipating another surge potentially from this? And what would you tell people ahead of time that are going to the game in person?
Yeah, that or concerts or other gatherings. Remember, transmission occurs person to person, and spending time in close proximity, especially in indoor settings, but even in outdoor settings in stadiums where there are large groups of people and where physical distancing isn't possible, does increase the chances that we will have transmission events. It simply does. What can individuals do to decrease their chances of that? They can take precautions like wear masks, even in an outdoor stadium setting where you're sitting around others. Wearing masks is going to be effective. I know it's not mandated, but it is effective. And I think thinking about it as a tool is important. And then simply knowing your risk is important. You know, it's very, we all want to continue to do the things that we enjoy. I love football. I love college football. I just wanted to re-emphasize that the way to safely enjoy those things that we all love is to break this cycle and to do the two things that we need to do to decrease the variance. That is to increase our immunity through vaccination and to decrease transmission by preventing those exposures. And if we can do that through policy, if we can encourage lawmakers to help the community to decrease transmission by using all of the tools that are available to us, we can be successful at breaking the cycle. And if we don't, I fear that we won't be.
Few more questions for you. So Idaho recently announced in Northern Idaho that some of their hospitals are doing what is called the crisis care level. And it seems like we're getting to that level potentially in St. George. Is there anything that Utah would do, or what does that even really mean for Utah, and how close are we to that?
We've been here before. Going back to December of last year, the state Crisis Standards of Care Committee gathered experts in the field and worked with government leaders and the Utah Department of Health to create a fallback set of a playbook, if you will, of rules that would allow decisions to be made in times of critical shortage that would prioritize doing the most good for the patients who are most likely to benefit. And that, just to reemphasize, is a place we do not want to be. It's preventable, and it's preventable by decreasing transmission. We don't want to be in a position where we're having to make decisions about whether someone gets a lesser standard of health care, whether they have COVID-19 or a non-COVID disease. We want to be able to continue to provide world-class health care to Utahns without compromising that. And the way to do that, again, I keep harping on it, but the way to avoid crisis standards of care is to prevent transmission and to increase immunity. We don't want to be there.
Yeah, and I will note too that Idaho does have one of the lowest vaccination rates in the country, which just kind of talks to you about the need to vaccinate and keep up masking. Last question for you before we take off for the day. Is there a vaccine that's better than the other? Have we found out any more data around if the mRNA versus the normal Johnson & Johnson vaccine is more effective towards COVID?
Yeah, we're good consumers and we care about whether one product or another is better. For preventing severe disease, preventing hospitalization, and saving lives, all three vaccines are equivalent. They're all excellent. And for achieving that goal of immune buffer in our community that will prevent the emergence of new variants, all three vaccines are effective and excellent. Are there some differences in the effectiveness in preventing new symptomatic disease? There are. We're starting to get data on that. It does appear that the Moderna vaccine likely does generate higher levels of antibodies, probably because it is a higher dose. We don't know whether that's going to hold true after the third dose. There's still a lot of unknowns around that. It does appear to be modestly more effective at preventing symptomatic disease than Pfizer, which also appears to be modestly more effective than Johnson & Johnson. But they're all, in the big picture, they're all very effective at doing what we need them to do, which is to increase that immune buffer and to prevent hospitalizations, ventilation, and death.
Dr. Webb, is there anything else you'd like to mention to us today before we take off?
Just to reemphasize our toolbox, let's continue to use all of the tools that are available to us, preventive and immune targeted. And I do want to maybe mention that the healthcare systems in Utah are working closely with the Utah Department of Health to increase our availability of monoclonal antibody treatments as well, which is another tool in our toolbox. It's not a substitute for vaccination, but it gives us yet another tool to fight this terrible disease. And because it's an important one and can be life-saving treatment in patients who are at very high risk, we continue to target the therapy at those patients who are at high risk and are working to increase our capacity statewide so we can treat even more patients.
Well, Dr. Webb, thank you so much for joining us and providing such great information this week. If you're watching right now and have you not been vaccinated and would like to find out information on where you can do so, you can go to intermountainhealthcare.org/COVID vaccine or go to coronavirus.utah.gov. As always, if you have any questions around the vaccine, please reach out to your provider, or those two websites also have great information if you do not have a provider on hand. Dr. Webb, again, thank you so much, and we'll talk to you later.
Thank you. Thank you.